audience here at the University of Illinois in the Department of Communication in historic Lincoln Hall. This is the third day of Health Communication, Barriers, Breakthroughs, and Best Practices, an online conference focusing on special topics in health communication. And this is our second year having an online conference like this. This year we're focusing on various aspects of e-health for our conference. Those of you who are seeing us online know that we've had two other keynote presentations this week, and the links to those presentations are on the conference page, in addition to about 24 other presentations that have been recorded and are available also on the conference page. And we encourage you to look at all of those presentations and to file your evaluations of those presentations for the benefit of the authors and your interaction with each other. I also want to mention that we've invited our undergraduates to participate in this conference this year, and some of them are receiving extra credit in their courses for participating in the conference and filing evaluations. And so if you happen to be an academic and are interested in making that kind of experience available to your undergraduates, please get a hold of us and we'd be happy to make that possible for your undergraduates as well. This program is brought to you by the Health Communication Online Master of Science program, and if you're interested in the HCOM program, as we call it, you can follow the links to hcom.illinois.edu and learn more about the online master's program. Today, our guest is Professor Sheana Bull from the University of Colorado School of Public Health, where she's the professor and chair of the Department of Community and Behavioral Health. She's also the Assistant Vice Chancellor for Digital Education for the University of Colorado, Denver, and the University of Colorado's Anschutz Medical Campus. She's a nationally recognized and internationally recognized expert in the field of technology-based health promotion, and her work over the last decade is focused on development, implementation, and evaluation of interventions using computer kiosks, the internet, and cell phones to facilitate HIV and STI prevention and self-management of chronic illnesses, including diabetes and heart disease. She's also studied the use of mobile and digital technologies for health promotion, including the exploration of engagement and dose response using text messages, apps, and social media content. Her presentation today is entitled, as you can see from our charts here, The Integrated Theory of mHealth, Why Digital and Mobile Health Must Embrace Multidisciplinary and Theoretical Perspectives. Dr. Bull, thank you for being with us today.
Thank you so much.
Welcome.
Thanks. So hello everyone, it's so nice to be here. It's my first time in Champaign, and hello to everyone online. It's with pleasure that I hope to persuade you around my topic about my call to use multidisciplinary theoretical perspectives when we're considering mobile and digital health. So I'm going to start with just a brief overview of what our field, when I talk about mobile and digital solutions for health promotion, what that covers, what the evidence is, where we are in the field, and where we hope to advance. I'd like to consider the use of theory in particular in mobile and digital health, and then introduce different theoretical perspectives than we're traditionally used to in the field, and then have a little bit more of a discussion about that. So that's our map for where we're going to go today. So first, let's just start with some definitions. When I say mHealth, it may be familiar to you as digital health or e-health, and I'm just using that term to mean the use of mobile and or digital solutions to facilitate both healthy behaviors, so directed at individuals, and then also to support delivery of care in clinical settings. And so it's not just consumer-facing or end-user-facing, but it can be a large suite of activities. And we've seen interventions that have used the internet. I felt pretty dated when Dr. Lammers mentioned computer kiosks, because you don't see those too much anymore, but that's where we started. And then social media, and we were actually starting in the field before the advent of social media, and now text message, more recently using apps and looking at apps, how they can facilitate health promotion. The use of artificial intelligence as well as virtual reality. These are new emergent opportunities for us, as well as machine learning and sensors. Is there anybody here who uses a Fitbit or has one on? Yeah? Okay, we'll come back to that. Good. So what have we learned from mobile and digital health research? So even as recently as maybe 5 or 6 years ago, I would have been one of the people calling for more evidence and saying that we have this dearth of evidence in the field. Now we're finally starting to really see a constellation and a concentration of studies, and including research syntheses and finally meta-analyses showing that mobile and digital health can be impactful. And so we've seen evidence that it can impact the antecedents to health behaviors, so things like your norms or social support or self-efficacy, things like that. We have evidence that it can impact health behaviors, things like smoking, physical activity, nutrition, fruit and vegetable consumption. Some of our work has looked at the use of condoms, sexual abstinence, as well as medication adherence. And then finally, our holy grail, at least in public health, can our interventions help impact health outcomes? We're starting to see evidence also that that will help. So we're starting to see a good number of studies and programs that have that efficacy. So I'm not sure if any of you would be familiar with any of these, but Mood Gym is a program that you can utilize as an app or through an internet interface for depressive symptoms. There's a number of smoking cessation initiatives, and actually smoking is probably one of the behaviors where we have the biggest amount of evidence for using technology tools. This is a device that's an app for facilitating diabetes self-management. We have, I don't know if people are familiar with this program, Text for Baby is actually one that was developed first and evaluated later, but some of the more recent evaluations have shown that it can be impactful for postpartum weight loss, for example, increasing physical activity. There's a number of apps and tools that are out there around physical activity more generally, not specific to the peripartum period. And then just a couple of examples of our own work. We were one of the first groups that used social media for sexual health promotion to reach secondary school youth and undergraduates, and targeting condom use. And then we've also worked, and there's a number of examples of using technology for health promotion and disease self-management in lower and middle income country settings. And it's been really interesting for south to north initiatives, where a lot of countries, because they have less in the way of traditional infrastructure, they've really made wonderful advances that are beyond our own in the higher income countries around health promotion. And this is a program that we worked on in Uganda, targeting secondary school students around HIV prevention. So just briefly, a couple people mentioned they use Fitbit. Are there other apps or programs that anyone here or perhaps online has used that they particularly like? One share?
Fitbit gives me more steps than my Apple Watch.
Mm-hmm. You're jumping to that. Anything I don't know if you dislike that or not,
Yeah.
But that's a potential problem, right?
I use a knockoff. Count if you're on an elliptical, it doesn't count
Right,
that unless
right.
you're moving your arms, and that was very frustrating.
Yeah, and it
'Cause I
looks
did all
kind of
that
weird
work,
to
but
wave
it
your
didn't
arms
happen,
while you're
yeah,
on
it
the
didn't
elliptical.
count.
Yeah, okay. Any other apps or social media programs?
I use Lose It to monitor the amount of calories. It's very easy. I love it.
Okay, and you like it because it's easy?
It's easy. It's also visual.
Okay.
So it gives you a little graph as you're losing weight.
Okay.
As big up as you're not losing weight. Yeah.
Okay, great. Anything else?
I use a couple of different exercise apps.
Okay.
Like high intensity interval training or like things like that.
Okay, and is there something in particular you like about them?
It just allows you to work out without having to plan it out yourself.
Okay. Right, a convenience factor.
I have a chronic illness and I have a small app that I use to track particular symptoms that are connected to that.
Okay.
And one of the things I like about it is I go to see my specialist maybe just once a year, and I can pull out my phone and give him a graph of, because sometimes like I might not remember in January what my
Right.
symptoms were in May, but we can go back and look at the calendar and kind of track, and it's real time, so it's not just me saying, I think this is happening, I do it every day.
Yeah. Okay, great. So there are a number of different options out there if you want to track your physical activity or manage self-manage a chronic illness, or as we've already touched on, a deal with anything related to depression or smoking, or there's other ones that are related to substance use. So there's a lot of tools and wonderful solutions that are out there. We do have a growing body of evidence, but we still have a bunch of questions that we don't really know the answers to. And I'm going to go through these in the rest of the presentation, but basically considerations of how we're getting the outcomes that we're getting when we note them, what's the right mix of exposure and engagement, how you reach highly marginalized groups. So arguably we've done a pretty poor job of that in the US at least. And then the lack of scale of our work. So I'm going to come back to all of those points. Okay, so there's a bunch of people here who teach public speaking, right? So I know I'm violating all the rules right here. Like I'm not supposed to put up stuff that nobody can read and it's difficult to follow. So here's this tool. So in here, these are all the first author and date of various publications that have been put out on the internet or text messaging, social media apps, games, sensors and trackers like your Fitbit, and then artificial intelligence and virtual reality. And really the point here, over here, is really the state of the field in terms of what has been done in our field related to research. So starting out with, efficacy for those antecedents to behavior change from a rigorous research trial to behavioral and biomedical outcomes, sustained evidence over 3 months, whether or not there's meta-analyses, et cetera. So the main take home that I wanted people to get from this is that we have there's a growing number of research studies in these areas that are filling in our evidence base, which is great, but we still have some notable gaps, right? So it's not so surprising that we don't have a lot of evidence yet on sensors and trackers and AI and VR, because those are new, and we expect those in the coming decade, right? But what's notable down here is that there's gaps across all of these related to, in particular, to replication of studies. We're having a real difficult time there. The scale of our programs, so whether or not we can disseminate them widely, and then really understanding the factors that contribute to our outcomes and our scale. So those remain essentially limitations that we have to overcome. So when we think about how those outcomes are realized, so this first issue, this is where I always turn to theoretical frameworks and the idea that we could understand mediators and moderators if we did a better job of really unpacking the pathway. And I wouldn't claim that this is only a problem with mHealth. Actually, I think it's a problem with most of our interventions. We know that they work or they don't work, but we don't know why they work or what's the right mix. But now, because we have the technology and access to data, we have a lot of opportunities to explore that further. And that's really related to this second point. What's the right mix of exposure? How many messages do people have to see, for how long? And does a message need to be different for a woman or a man, or an older person or a younger person? Certainly, of course, the health communication people will obviously know that you can't say the same thing in the same way to somebody like me as you would to my 16-year-old daughter. So she regularly reminds me of the way that I'm just doing it wrong. So then we haven't done a good job of reaching highly marginalized groups. This is really a big gap. So arguably, a lot of the technologies that we have aren't designed with people who face multiple chronic conditions, who have disparities in health outcomes. That's not the audience that they're being designed for. And we have a pretty big gap. You know, we have industry creating these tools. They're not necessarily bringing the people that they that could be using them and could be benefiting from them to the table, right? They would like to sell their app in the App Store. And they don't necessarily care about maybe a Latina mom who's got diabetes and her child is overweight, for example. And then finally, this last point, you know, really we think that mobile and digital health can be impactful because of reach. So I don't, most of the time we're not seeing people make claims that a mobile or digital program or solution can replace a face-to-face intervention in terms of its effect size. So you could get great and more intense effects in a group level education session, for example. But you can't replicate that session very easily at cost. And so where we're really going to have benefit is spreading our work to a lot of people. So you might have smaller effects, but if you reach more people, you'll have greater impact. So this is where, you know, I really would love to see our field expand more than anything, because if we could really disseminate, then we can really have a better sense of our impact. So here, this is where I want to circle back to this idea of our theoretical perspectives. So on this, I don't want to suggest that this is anything but, you know, what you might see typically in health behavior interventions and the frameworks that guide them. People, you know, may focus more on social support, or they may suggest that self-efficacy is key, and they may have a different pathway that are achieving these outcomes. But these are often where people fall to when they're developing their programs, and they think about certain traditional theoretical constructs that are thought to and demonstrated to affect behavior change. And they are important, and I'm not suggesting that we don't use them. What I am saying is that in the technology environment, we have so much in the way of competing priorities, right? We use, and I'm tending to outsource my phone for everything now, but we use our phones and our technology for more than just health promotion. So we have competing demands on our attention. And so what I'm suggesting is that in addition to these, you know, typical types of theoretical constructs, we need to pay attention to two critical areas, and that includes access and engagement. And I'll elaborate on those a little bit more. But especially the undergrads who are watching or participating, this might not be a surprise to them, but you know, we do a lot of work with young people, and we're seeing that on a daily basis, they might engage with 300 or more text messages, right? And that's just on Snapchat. And so, let alone what they're doing, they're posting on Instagram or, you know, getting phone calls that they ignore from their parents. So I think the idea is that people are bombarded with information, and we need to make our health communications online resonate for them. And so I'm going to start with access, and I think access is a critical point. So instead of, the first idea here is kind of hearkening back to, people might have to dust off the cobwebs here or think back to their, you know, undergraduate philosophy classes to think about some of these ideas. But the first two from Karl Marx are perhaps the cautionary tale, right? So this idea of commodity fetishism, that we get seduced by the bells and whistles that are out there, and we may tend to develop something because it's sexy or because it's a new technology. So that's something to watch for. And then the idea of alienation. We may deliberately try and make something more convenient, but if you're taking people away from a social support network or an environment where they can interact with real people, you may increase their sense of isolation. And then a counter to those relatively negative ideas that you're trying to avoid are two around democratization of knowledge, and we were talking about this a little bit at breakfast this morning, this idea that, you know, you have this environment where you can really facilitate a conversation and get more people access to information in a way that's not been possible before. That from Michel Foucault, and then Paulo Freire and this idea of co-creation of knowledge, using the environment to really co-create new ideas and have a collective efficacy. Now, of course, we've seen the possibility in social media of these things going very wrong, and so that has to be managed very carefully. But the idea here is that you really think about incorporating these concepts in the design. So really think carefully about who your audience is and what they use, so that you're not building a totally new system that has bells and whistles when and has an app that you have to track everything or you have to report, when really a simple text message program would do, and it would reach more of the people that deservedly need it. You would be trying to make sure that we can use tools and strategies that keep people connected to services or serve as an extension of those services, rather than designing a lot of separate standalone programs. And then, of course, carefully manage the knowledge sharing process and encourage people to bring in their own expertise and their own lived experiences to facilitate behavior change. The next domain that I think is important is the one related to engagement. And here's another, so we expanded beyond your traditional health behavior change theory to think about some of those larger meta theories. And now I want to leave our social science field altogether and go into computer science, because this is what they've done really well, and think about the user experience and user engagement. We'll argue, you know, in public health, you know, I always kind of think we're relegated to the public service announcement that's on your local cable channel, you know, showing at 12 midnight till, you know, 12:15 because you don't have any money, right? This is the same kind of thing, is that unless we do a really good job with the user experience and user engagement, the technology development from the user perspective, no one's going to pay attention to us. So this idea is simply that you really have to be careful to create something that works. You can log in easily, you can turn it on, you don't have errors, it's easy to learn and it's easy to use. There's some evidence from industry that there's something on the order of 165,000 apps out there now, just apps, related in some way to health. But less than 10% of them have been downloaded. And then once they're downloaded, the median number of times that they're used is once. And it's largely because of this issue, because the folks who are developing them haven't done the work with the end users to really make sure that they're easy to use. And like you mentioned, the thing that you like to use is easy and it's simple and it provides you a good benefit right away. And so those are some things to consider as well. The other element of engagement, of course, is very central to this audience, and that's the use of health communication theory, especially around development of your content. And that's separate from that content that you want to increase somebody's self-efficacy or build a social norm, but really much more around what is the specific message saying and how can you say it. And this is really becoming more and more critical. And is there something around the way that we craft our messages that makes people pay attention? These are, of course, only a handful of theoretical perspectives that you can use, but illustrative of the types of things that we want to participate or engage in. So the technology environment forces us to pay attention to those design issues, making sure that it's easy to use. And then people are bombarded with those messages. With 300 text messages coming in a day, you know, maybe that's not true for this audience, but for a lot of the audiences that we want to engage, we have to make it exciting and interesting. We were talking about that a little bit last night with Brian. You know, how do you make it so that people enjoy the experience and they want to keep coming back? We know a little bit from, this is from a marketing professor out of Penn, I believe, and he talks about this work that resonates a little bit here too, and maps to similar kinds of ideas in health communication. And he came up with this acronym STEPS, based on research that he did looking at what makes messages go viral in the social media environment. And the first is that they don't have to have all of these elements, but if they have a couple of them, or at least one, they tend to be more likely for people to post or share. And the first is status or social currency. If a message is going to make you look good, like you look funny or you look wise, or something that, you know, people would admire you for posting, then you will be more likely to post it. A trigger, this one is interesting, and we're starting to explore this as well. You know, in the elaboration likelihood model, you've got the idea that you want to get people thinking that something is more central, more relevant to them. But the trigger concept in the social media environment suggests that that doesn't always have to be the case in order to get people to behave, right? And we've seen this, especially around medication adherence. Just a simple alarm on your phone helps you remind you to take the meds. You may or may not have embraced the centrality of the importance of doing that. Emotion, we know that messages will be shared if they evoke a strong emotion. Anger or love or humor, for example. The one thing we know about this is that you can't have something that's too sad. And it's what he found is like the Humane Society messages, you know, it's just too difficult to look at those starving animals, and so people click through and they don't pass it along. So you have to be careful with that one. The public is really more of the brand or the group that you're with, and this is, at least in public health, we think this is really critical because this often is really the only source of credibility and can help us when we're competing with other demands and other perhaps sexier messages. Practical value is kind of maps to this self-efficacy idea. If it's going to give you some sort of skill or some sort of immediate thing that you can do, you know, I have, I don't really post on social media, but I have all these accounts. And my sister-in-law posts all the time on those really quick menu things or recipe things. And so, you know, it has 30 seconds and you learn how to make a cake in 30 seconds. And I think, oh, well, if I made a lot of cakes, that might help. Oops, and I skipped. And then the last resonates for narratives, and it's the same thing. You know, if you're telling a story, it's more compelling than perhaps even sharing data for a lot of audiences. So again, really, if we're going to be thinking about theory as a way to help us move our field forward, we can use those types of theoretical perspectives, particularly in mHealth, thinking about access, thinking about engagement, as a way to further understand what is the process by which our outcomes are realized. And then it can help us now, we're in a nice position also to be able to really study dose response. If people will engage in our messages and we figure out which ones are engaging, then we can figure out how many messages do they have to see, how long do they have to engage in them before we get the benefit that we want, and then how much booster messaging do we have to do in order to retain that message and avoid decay. And then, of course, certainly the idea of democratization of knowledge and co-creation of knowledge is an opportunity for us to think about using these tools to reach people with our interventions that really traditionally have been left behind, particularly in mHealth. And if we can do all that, then we're in a position to be able to disseminate something and say, okay, we know it works, we know how much you need, we know it can reach people who need it, therefore we have a better opportunity to scale our work. So I encourage you to use this model or to think about, particularly these two elements in doing your work. And that's all I have. So what questions do you have?
Sure.
Okay. Question from, I always butcher her name, Suleiman Koulibaly.
Oh, Suleiman
she's-
I'm thinking that's my student.
Okay.
A plant.
And if I'm right, it's a he, and he's from Cameroon.
Okay. Well, he says great to have Professor Bull, so that makes
Okay.
sense then. He says, from a public health perspective, who is going to pay for incentives services for mobile health solutions? Governments, nonprofit organizations, or the public?
Yeah, it's a great question. I don't know that I have a good answer, except to say that some of the work we could do, particularly around evaluation of impact, might help us. I think you have to do that work on, the economic return on investment in order to demonstrate the value of doing that type of program and using mHealth programs. So it's tough because we have to first evaluate it, which is expensive, and then we have to convince the people who are in positions of decision making in different public health agencies to adopt this instead of something else. But I think the whole idea would be to really emphasize that scale. You can reach more people, you can have a positive impact, and then it helps to make the decision a little bit easier when you have limited resources. But I think that's probably easier said than done. Yeah.
You mentioned replication,
Mhm.
and it's a hot topic because lots of disciplines are dealing with that problem right now. Is your sense that no one's trying to replicate the studies, or that they're not working?
That's good. I think I want to say that it's probably both. So in mHealth, we do have an example of something that's been replicated and hasn't worked. So this is a text message campaign that was for HIV testing in East Africa called the Well Tell Project. And it was a very simple campaign, and all they did was send out a simple reminder, hey, it's time to contact your health provider once a week to people who are living with HIV so that they could stay on their antiretrovirals. And this was in Kenya, and then they replicated it, I want to say they replicated it in Cameroon, but I might be wrong, I think it was West Africa when they replicated it. Now, and they didn't show the same effects. And in that program, I suspect that between the time they did it the first time and the second time, the field has evolved and our environment has evolved. So they did it the first time, and text messages were really novel, unique, not very common. And then by the time they're replicating it, it seems to me, now I'm guessing, but it seemed to me that they were already in a place where they're competing with all these different message senders. Then people were getting competing messages from whoever they would get messages from. So I'm not sure if that would be the reason. But I think there's a lot of times that we can't replicate. I mean, at least in public health, I know we have a big problem because it's not considered novel enough, so you can't get funding to replicate. So that's a real challenge that we have to overcome as well. Brian.
Sheena, great talk.
Thanks.
This is really thought-provoking, and one of the things we're working with right now is engagement, and we're trying to find the best way to measure it.
Mm-hmm.
So I'm wondering if you could unpack that concept a little bit more in terms of how you conceptualize it, and also how are you measuring it?
Mm-hmm.
Like, what elements can you actually observe and say, okay, this app was engaging?
Yeah. I think that's a great question too. I mean, there's certainly just your basic assessments of how many messages did people see, how long did they spend on a message, did they share a message, and you could do that in social media. You can do it in some text messaging programs. The text messaging programs are a little bit harder because when we've done that, we don't do it on every single message because we feel like people would burn out if you ask them to respond. And then if they're, and you can't really measure whether they're engaging with it unless you ask them to respond. Because if you just know that your system has sent them a message, you don't know that they've read it or internalized it in any way. So we ask people to respond to a certain percentage of those messages, and then we just analyze that. What did they respond? And if they responded more, do you have a better effect? That's kind of the simplest method we've used. But I think, like you and I were talking about this last night, there's an opportunity, I think, to get at this more qualitatively and sit down with people and say, what is it? And maybe you want to do that even before you design your program for that kind of Paulo Freire co-creation idea where, the audience has really good ideas about what resonates for them, and this is why you want to get, if your intended audience is college age, you want to get them sitting around the table and saying, no, you have to say it like this and not like that, or, you have to be careful about who the messenger is, things like that. Just those traditional approaches are probably helpful.
We have an online question from Claudia Montero. She says, hi, congratulations to Dr. Bull for her presentation. One question, how would you go about evaluating the cost effectiveness and quality, defined how, of e-health programs for health behavior change?
Yeah, so we're just starting to see some of this, and in a couple of our research projects right now, we're working with health economists who are doing a return on investment type of analysis. And so what they're doing is really a traditional cost effectiveness type of assessment where they have, they've documented all the costs, not for the program design as much. They spend more time focused on the cost of the delivery of programs. And so then they can be more cost effective, but then it's going to be hard for us to really say that definitively yet because we don't have the scale of our program. So right now we're kind of stuck with a modeling approach. We don't have any actual good data on it. So they can say, well, if you were reaching this number of people, this is the impact that or this is the cost effectiveness return on investment that you would potentially get. But because we're not replicating and scaling yet, we can't really answer it. So I'm not sure if that gets at everything. Do you want to repeat it so I can make sure I did?
How would you go about evaluating the cost effectiveness and quality, in parentheses, defined how, of e-health programs for health behavior change?
Yeah, and then the quality side, I think, is back to this idea of engagement. How do the messages need to be designed in such a way that people will actually pay attention? And so it seems to me the quality is part of the efficacy question. If the idea is you have to get them to engage first before they will then share with their networks and generate any sense of social support or self-efficacy, then you have to pay attention to the message design. And then it seems like you only have to have that operating at scale before you can really say something about the cost effectiveness. We think it's there, but I don't know that people are doing that widely enough for us to be able to say exactly how cost effective, especially compared to a head-to-head to another program. Yes?
Thank you. I'd like to add my thanks for your presentation. It is thought-provoking, and I really do appreciate your move toward bringing theoretical perspectives from across the social sciences, to inform this. Although, and maybe this is part of the intention, for me, it raises more questions than it answers. So the first question that I have is that you've arrayed these two more recent ideas of access and engagement that influence behavioral control and et cetera, without seeming to be interdependent. Isn't it logically the case, or did you already say it and I just wasn't paying attention because my train of thought had left the station, that engagement really kind of depends on access, right? Or am I wrong about that?
No, you're not wrong. I think that's probably a good point. You could link those two, or maybe have access first, or even on the left of engagement, right? Because if people can't see your program, then they can't engage with it, for sure. Right? Or if they can't open it, or they keep finding errors, or, yeah, they're never going to get exposed.
Well, I'm just thinking out loud here, and I might be just revealing my ignorance, you know, as I do. But one study that came out about a year ago suggested that people believe news items more if they were passed along by a friend than if they encountered it themselves. That they attach a higher veracity to an account, and this is part of what is, I guess, undermining traditional institutions via, you know, the global data network, because I don't believe the newspaper, but I'll believe the newspaper if my friend sends me the article to it, right? And if my friend sends me the article that says that vaccines cause autism, then we got ourselves trouble.
Right,
And
right.
you know, so this is beginning to hint that actually social network sharing influences engagement.
Yeah, I think this is where this part is so critical, because this, you know, democratization of knowledge, these are very idealistic, but the reality of particularly our social media environment, is that it's such an echo chamber, and people are really narrowing their exposure rather than broadening it, unless they're critical about what their friends are saying, right? So it feels to me like this is you have to navigate this space really very carefully and really understand what is it that your audience finds credible and why. I think it's a much bigger question about how people adopt and develop their critical thinking skills, but that's probably, my friend says that's a different Oprah. Right, you go. That's a different Oprah. Tomorrow on Oprah. Yeah. Did you have a question?
Yeah, in line with John's question. First of all, thank you for a wonderful presentation. So when you estimate the effect of some mHealth app or device, but like people getting similar message about the topic through different channels, because they're already embedded in social network,
Right.
and using different social media. Even if you're using diet app, for example, if your friends are keep posting a picture of pizza on Snapchat, you would like to eat more.
Right.
So how do you control all these extra messages when you measure the impact of mHealth app?
Right. Yeah, and I think this has been a challenge for us. We started out, for example, on an earlier study that we did just on the internet before really social media was around, and we were comparing a much more interactive HIV prevention program delivered on the internet with a standard HIV prevention program, and we saw almost no difference. And so when you're comparing similar content, I think that's really quite difficult. And so that's where I think the questions about dose are potentially very helpful for us. Because right now I don't think that you can control for it all that well, because you can't really ask, people aren't really good at being able to say what they've been exposed to. You can only kind of guess at that, right? Where we left from that research was then to say, okay, let's do something very different, right? And so we've since done, comparisons of like a fully engaged text message program about smoking cessation with a banking, a financial maturity kind of program. So here's how you manage your finances through text messaging. So we know that it's more like an attention control approach. So the people are exposed to all of the same social media environment except this one element. So if you have attention control in terms of the content that you're doing, you get closer to it, I think. But I think that now we're able to do more dose response. You could get at that even a little bit more. So you could say, how many of the messages in this program did you have to see before you got a benefit with an attention control arm? So did they see the same number of messages but about a different program and see that outcome? But we were only starting now in dose response. It's new.
We have another online question. This is like from Nadine, University of Amsterdam. Great presentation, thank you. Besides the challenges of mobile technologies to engage their users to continue using their health apps, what is your opinion on engaging those who are not yet using?
Okay, so besides the current engagement for people using apps, what can we do to get people who are not using apps to engage? I think that really comes back to the process, this process right here of access. You really need to be talking to your audiences before you design your programs and figure out what is it that they're likely to use and how to get their attention. We were out to dinner last night with your presenter from yesterday, Kim, and I didn't get to see her talk yet. I'd love to be able to go back and see it online, but it sounded like one thing that she was dispelling was this myth around older folks engaging with content online and using a technology platform. And I think that's part of where we fall short, is that we make assumptions about our audiences that they can or they cannot, or they will or they won't. And I think we just have to ask them more and also figure out what it is that they're using through other mechanisms. And fortunately, with the technology environment, you've got, and one of my favorite sources is Pew Internet and American Life. And they've got, dozens of kind of, and continually update their profiles of the online environment and the social media environment, what people use, who's using it, how often they're using it. And they're the ones that are talking now about almost universal saturation of internet access and cell phone use, and they've put out more information about how people engage less with apps, for example, but text messaging is very popular. So I think that's really at the core here, that we need to just honor what is our best practices among our methods and go back to our audience and make sure that we can ask them and not assume. Great, yes.
My question is kind of the other side of Jay's question, which is, are there examples of, I don't know what you might call them, hybrid campaigns, where you have an mHealth component and, let's say, a more traditional public mass campaign? I'm thinking about, could you have a campaign related to binge drinking for students, that there would be an app, but then there would be billboards on the buses that go by on campus.
Yeah.
And what sort of challenges does that introduce into the mix, or opportunities, right? Because you then, to a certain extent, are attempting to intervene in the larger messaging environment at the same time.
Yeah. I mean, I love that idea. For me, it makes a lot of sense, because most of the time, what I sense is that people are not using their technology to replace something that's happening in the real world. You're using it to enhance or extend it. So the idea of hybrid programming is really appealing. I don't know of programs that have really utilized that in a rigorous research trial. I think there's a lot of methodological stickiness to try and figure that out. We're right in the middle of this. We're working with the Colorado Public Health Department to do a colorectal cancer screening. March is colorectal cancer screening month. If you're 50 or over, go get your screening. We're doing a screening campaign with them where they have radio spots in the San Luis Valley, which is a rural, small community. And they don't have a lot of access to broadband and wireless. And so we wanted to do text messaging. It's that question of, what is your population using? Don't do a lot of bells and whistles. But we wanted to drive them to the text message campaign. And people aren't going to just all of a sudden get text messages. We don't have their phone numbers. So we attempted to drive them to the campaign with radio ads and with billboards, but we're just starting to see some of the data there. It's kind of mixed. So I think some of that is a cost issue. They just didn't have a big enough budget. And we're not doing it as part of a research study. It's just a public health program. But that would be an idea. It seems to me like if you want people to see your messages, you have to get them to give you their phone number or get them to sign up in some way and opt in. So that's a big challenge. We saw another program that we did do with a rigorous evaluation, and that was in combination with the Boys and Girls Club around a teen pregnancy prevention program. And that was a little bit different. It's not like two different communication programs. It was one in-person group level intervention with kids meeting weekly that was supplemented with text messages. And in that one, the comparison group was the traditional group session that didn't get supplemented with text messages. And there we did find some positive effect, but we couldn't find the behavioral effect. We found a reduction in teen pregnancy, but nobody said that they started using contraception more, so we couldn't figure out why they weren't getting pregnant anymore. Maybe they were having less sex, I don't know, but we couldn't really tell because there were not enough of them having sex. So that's not typically our problem when we work with adolescents. But in that case, that was a nice example of a hybrid program that I think we're underutilizing the opportunities there. There's lots of ways that you could cross-fertilize or use this in addition. But again, the research methods then they're always challenging in the large communication campaigns. I think this becomes even more so because you have to lock down your social media, make it private groups or only to people. People can't share the messages. It's really tough then to control the exposure. Mm-hmm.
I have another
Okay.
question. Going back to the model that you're working on as an organizational communication fellow, I look at models like that and think to myself, there must be an organization in here somewhere. I mean, these models sort of begin with rooted in an interpersonal communication or interpersonal psychology kind of foundation, but they have implications for social structures and arrangements and so on and so forth. But thinking about formal organizations a little more specifically, I was wondering if you could comment on the role that they might play, both with respect to access and engagement. And what I'm thinking about right now are some things that have been regarded as somewhat controversial. For example, a couple of years ago, I think it was Pennsylvania State University, and there have been plenty of cases of this, had a bit of a dust up because it, through its employee assistance program, had engaged its health plan to require the employees of the university to declare whether or not they were smokers. Oh. And when they did, their insurance rates
went up.
were increased. And so there's one, okay, that's one, and we're, the Affordable Care Act, in its attempt to standardize the package of health, services that are in a health plan, it sort of pushed back on some of that, but at the same time, health insurance companies are trying to, predict their costs associated with health
Right.
behaviors and so on and
Right.
so forth, and they're sort of moving, in those directions, just like car insurance people say, if your kid is accident-free or gets all A's, they have a
Yeah.
lower. So, they're working on that historical rating of business. So park that for just a second. And now, we do actually have a public health problem, as I'm pretty confident everybody in the room will agree, with gun violence in the United States. And, and we have this little ritual of, we're going to control it and then we don't. Except that in this most recent iteration of public discussion about it, we found organizations beginning to step up. So we find Walmart saying, people are going to have to be 21. We found that Delta Airlines is not going to allow a break to NRA members and so on and so forth. So I'm just wondering, with respect to access and engagement, is there some role that corporations, private enterprises, the marketplace might play outside of the public policy side?
Yeah, I mean, it's a question that I think is unfolding right now, right? I mean, I think that it seems, from what I'm observing with the recent gun violence and the students, is that they're really harnessing, and I think what they're doing is they're carefully harnessing this co-creation and democratization of knowledge around information at scale. And that seems to me to be what's driving the corporate response. I think the corporations wouldn't have done it without that activism, right? I think, and I don't know, I've had lots of conversations with my friends and family and neighbors and things like that around, well, why is this different? I mean, I can remember in Sandy Hook being so overwhelmed and thinking, oh my gosh, this has to be the time when we're going to have some sane response, but it didn't happen, right? So I think that's what we're seeing, that the young people have perceived an opportunity, and maybe they didn't even realize how big it would get, but they just felt like they had to act, and they have this mechanism now where they can get their information out and share it. I don't know. I mean, I think it's a great thing to ponder.
Well, I guess just to say at the theoretical level, maybe bringing in some aspects of collective action and social movement theory might inform these issues of access and engagement. Because
Right.
engagement is definitely, like you said, sort of being driven by the millennials who are simply stepping up and saying something. What's just at least curious from a sort of theoretical point of view is that the corporate community seems somewhat more, at least early on, responsive to this social movement than the political
legislative,
community.
yeah.
Sort of fascinating.
We have another question from Nadine online. What's your opinion on the increasing use of personal data in mHealth to increase engagement? Would it increase engagement because of more personally relevant triggers, or would it scare people away?
Yeah, I think that's one that you have to monitor and manage quite carefully. We've heard the whole range of responses where some people really love it and they like this digitized self and the access to always ever growing data and information, and then we've heard other people who are really worried about it. And I think I can't say much in direct response to this question that I feel like I have an answer to. One thing that I would say is that it's incumbent on us to always approach this very responsibly and ethically. And if we're going to be collecting data on people, to do so in a very transparent way and to really make sure that people are aware and buying into that and have agreed to it. And need to do that with also a very deliberate approach afterwards of being responsible for what we do and how we guard those data. I think in academics, perhaps we have a history of not always doing that well, but now we have an environment that can support it with all of our IRBs, we have examples of the social media corporations like Facebook, for example, and we see it every day. You know, they're collecting data on us, and you can tell because when you shop for X, you start getting those ads, right? And those are artificial intelligence algorithms, so there's not one individual that's looking at your data, but they can. So all I would say is that I don't know the answer to the question, except I would use it as a way to encourage ongoing attention and adherence to the ethics of our work around protection of the process and the data, for sure. We could really risk further breaks from communities, especially if we want to get more communities that could benefit from technology to use them. They may be even more suspicious if we don't do that well, so we risk a lot.
One more
Okay.
general question.
Mm-hmm.
So when you talk about the scale of the campaign, for example, and sometimes like when you find experiment setting laboratory doesn't hold up when you scale
Right.
up. Like in that case, do you have any experience like that, or like in that case, what happened? What do you trust more?
Yeah, so I haven't seen a lot of examples of things going to scale. One is Text for Baby. But the challenge with that, they started that program first and evaluated it later. So they didn't start in a laboratory and grow, they grew it, and then they started picking pieces of it and evaluating it that way. So they haven't gone a traditional route. So it's hard to say whether or not they have uncovered any problems, because they started with their full campaign and then they've slowly evaluated pieces of it. I don't know of examples where people really have truly gone to scale and looked at whether or not the impacts hold and the effects hold. I think then there is a challenge, like you have to plan for that. Well, what happens if you see some negative outcomes? There is one on this, horrible slide that the red actually refers to things that had negative outcomes. And so here, for sensors, for example, there was an app that was supposed to be measuring blood pressure, and it had not been well validated. And so it was out there and people were using it, and one physician started using it with his patients and found that it was actually misreading the blood pressure. So to the points that people were making earlier about their Fitbit, it's not so much of a problem if your Fitbit is miscounting your steps, but it's a big problem if your blood pressure monitor is not monitoring well. So there could be real ramifications for taking it to scale if you don't do it in the right direction. So I mean, Text for Baby is an example of something that started with, and a lot of these do, they start with an organization that would like to sell their widget in the App Store. So it kind of just speaks to the need for better partnerships between, academics or public health agencies and industry, and we haven't gotten there yet. So thanks everyone for coming. I really appreciate it. It was good to be here.
Don't leave just yet.
Okay.
I want to add once more my thanks for your presentation, and to thank everybody who's participating remotely. You might have heard that one question we got today for Dr. Bull came from Santiago, Chile, and another question that we heard today came from Amsterdam in the Netherlands. I tried to figure out how many miles apart those places are, but my app said you can't get there from here. So I think you know that it's far away, but I'm welcoming all of you, and I hope that you'll do one more thing, and that is tell your friends about HCB3, and don't hesitate to give us comments and reactions to this presentation, yesterday's and the days before. Thanks again, everybody, and thanks again, Dr. Bull.
Thank you.